Good morning, ladies and gentlemen. Thank you, Prof. Alicia. So thank you for that kind introduction. I only read some of it. And thank you to the organizers for the kind invitation to speak at this inaugural National Cancer Congress. Massive congratulations to both NCSM and Sunway University for organizing this event. I think it's a great initiative, and I hope it'll be the first of many cancer congresses in the years to come. So the focus of my talk this morning, it's the first of 3 or 4 talks in this session, is to let's discuss how we can integrate AI technology, right, to optimize and enhance screening for lung cancer to improve detection of early stage disease. Next, please. And I think it's important before we dive into the AI per se that we have an appreciation on the need or rationale to screen for lung cancer. And I want to share with you all briefly the burden of disease, the scale of the problem globally as well as here in Malaysia. And also I think let's look at what are the barriers for screening for lung cancer and how AI could potentially mitigate or surmount some of these roadblocks as well. So that's very important. Then I will, sorry, we just go back a minute. Yeah. Then we'll also look at how we can integrate in terms of the clinical workflow. And finally, what is the potential for AI, as well as some of the limitations, impediments to implementing AI. So very briefly, and I appreciate this being a cancer congress, everyone will be very familiar with the landscape. But as far as lung cancer is concerned, globally, it's the most common cancer, most common cause of cancer death. Around almost 2 million cases globally each year. Around 1.7 to 1.8 million people succumb to the disease each year. In Malaysia, it is the most contemporary data we have is from our National Cancer Registry report. As you know, the Ministry of Health issues this report every 5 years. The latest report is overdue, probably delayed because of the pandemic, but it's a 5-yearly report. So this is the most sort of publicly available contemporary data. And you will see that it's a very common cancer. Among Malaysian males, it is the second most common male cancer. Accounts for almost 15% of all male cancers in this country. Marginally surpassed by colorectal cancer. And you can see the age standardized incidence rate of about 13 per 100,000 in the population. In women, it's the joint 4th most prevalent cancer at 5.6%. So I think we can all agree it's a fairly common malignancy in our country in keeping with global trends. However, more alarming is if you look at the bottom left, the bottom right, is that pie chart which demonstrates the stage of disease at initial presentation. And we can see this is Malaysian data, very alarming, almost 95% of Malaysians at the initial presentation, initial diagnosis by the doctor, they are in stages 3 or 4, locally advanced or metastatic disease. And for all the tremendous advances that we have witnessed in the diagnostic and treatment landscape with lung cancer in recent years, I can tell you these treatments are non-curative when we are dealing with more advanced stage disease. Next, please. So why the importance of early diagnosis? I realize I'm preaching to the converted here, but all cancers, and especially lung cancer, the treatment that we offer, the prognosis, the outcome is very much stage dependent, okay? And we can see from our own Malaysian data, this is the MyScan data from the National Cancer Institute. This is data from 2007 to 2011, published in 2016, 5-year relative survival. In pink, it's the 1-year survival, and in purple, it's the 5-year survival. And we can see how the survival, as you would expect, diminishes significantly as we move across the stages of the disease. Now look at global data in the bottom right here. This is from the IASLC, International Association for the Study of Lung Cancer. And I can tell you that if we look at the 5-year survival, the best case scenario is a stage 1A1. So this is a patient with a small tumor, by definition less than 1 centimeters, fully removed, no spread to lymph nodes, no distant spread. We can achieve a 5-year survival in excess of 90%, and that's brilliant. Contrast that with stage 4 disease, where we're talking about a 5-year survival around 5 to 10%. So I think this underscores cancer in general, but lung cancer specifically, the importance of early stage diagnosis or detection. Now, how does Malaysia compare? We benchmark regionally. So this is a 5-year relative survival looking at all stages of the disease. Okay, stage 1 across to stage 4. And we can see our East Asian cousins in Japan and Korea, the 5-year survival around 30 and 20%, which is 2- and 3-fold higher than the relative survival for lung cancer in Malaysia, which is only around 11%. And the reason for that I can share with you is it's largely driven by stage shift or stage migration, because they are far more sophisticated in terms of the screening. Next, please. So the next question then is, how do we screen for lung cancer? At the present time, the standard of care, the imaging modality globally that is accepted and is proven, is with a low-dose CT scan, LDCT. For non-clinicians in the audience, this is a non-contrasted CT scan. So the person or patient does not need to fast. You don't need a prior blood test. It is a rapid acquisition, single breath scan, takes about 15 seconds to do. And it provides very detailed, high-resolution images of the lung parenchyma, the lung tissue, sufficient to diagnose an early lung cancer, which usually manifests as a nodule. And the purpose of this talk is to explore how we can utilize the humble chest X-ray as a step before that, because there are issues with LDCT and AI-enabled chest radiography. So that figure there is an illustration of a typical early-stage lung cancer in the periphery of the upper lobe of the left lung. Next, please. So very briefly, the evidence base or the data to support LDCT screening for lung cancer comes from two major trials. Probably you're all familiar with it. One is the National Lung Screening Trial, published in the New England Journal in 2011. Basically, they looked at almost 54,000 men, smokers aged, it was a Pan-American study, smokers aged 55 to 74. So they focused on people with a tobacco smoking history, current or former smokers. And they were able to demonstrate in the two groups, when they compared serial low-dose CTs, 3 annual scans versus conventional chest X-rays, those that were screened with the LDCT, you can see more cases of lung cancer being detected. And more importantly, there was a significant reduction in the lung cancer specific mortality, a 20% risk reduction from premature deaths from lung cancer in the group that was screened with the LDCT, and an overall 7% reduction in all-cause mortality. One of the concerns, however, with the NLST was about false positives. There was a high false positive rate, in other words, a slightly reduced specificity. And as you know, that increases patient anxiety. It can also lead to unnecessary investigations, including invasive biopsies. Next, please. The other major trial to cite is Nelson. So this is a Dutch-Belgian study. And what they did was they included women, unlike the NLST, and they dropped the age criteria. So now we were looking at individuals aged 50 and above. And the smoking history, if I'm not mistaken, was not 30, but 20 pack years. And they were able to demonstrate more impressive results. This was published at the World Congress in 2018. 26% risk reduction in lung cancer mortality in men over a period of 10 years. And in women, the mortality risk reduction was more impressive, around 40 to 60%. Now, one of the things that Nelson did, the Dutch-Belgian study, is they introduced volumetric analysis. So they were able to look at, the tumor doubling time, the increased serial imaging, increasing the size of the nodules. And in doing that, they significantly reduced the false positivity. In other words, they improved the specificity. Next, please. Finally, a bit of data. We always talk about trial data. Sometimes there's criticisms, they don't reflect real-world practice. So hot off the presses, this is published in the journal Cancer. This is a real-world study, and this is, you'll be familiar with the Veterans Administration health system in the United States. Almost 58,000 patients, fairly contemporary, 2011 to 2018. Of this cohort, all of them had lung cancer, just under 4% were screened prior to the diagnosis. And you can see, if they look at the bottom right, the effect of screening, significant stage shift or stage migration, that in those who were screened, a higher proportion of stage 1 disease, 52% versus 27%. And that translates into better overall survival at 5 years and better lung cancer specific survival as well at 5 years. So we see the value in screening in stage shift, because early stage disease is more amenable to treatments with a curative intent. Next, please. So I hope at this point I have convinced you agree on the need, the rationale, the need to screen for lung cancer in our country, and what is the imaging modality at the present time. The next big question we have to ask ourselves is who do we offer screening to? So NLSD and Nelson, two globally cited trials, provide compelling level 1 evidence that we should offer screening to individuals with a significant tobacco smoking history. The NGO that I lead, Lung Cancer Network Malaysia, we have refined some of that, contextualizing local demographic data from our own National Cancer Registry, and we have advocated that people who are current or former smokers of at least 20-year duration and in that age group should be offered or counseled or given the option for LDCT screening. Now, there is another big group of individuals that if we rigidly apply this current screening criteria, we fail to capture. So whilst lung cancer traditionally and still remains largely a male smoker's disease, I can tell you all, unfortunately, we are starting to see increasing numbers of cases of lung cancer in the non-smoker or never smoker. And anecdotally, more than half the patients that I operate on for lung cancer are non-smoking Chinese females. That may also reflect the demographic of the hospitals I practice at. Other risk factors that we know, obviously air pollution, exposure to secondhand smoke, etc. But these are more difficult to nail down, to quantify. Next, please. So this was an editorial that I wrote, I think, about a year ago in NJM. And the graph at the bottom is not from that paper, but have a look at that. In 2020, globally, lung cancer amongst non-smokers was the 5th leading cause of cancer-related mortality. Now, isn't that alarming? In other words, more people die from lung cancer in non-smokers and never smokers than from other malignancies like colorectal cancer or pancreatic cancer. So we can see this is no longer just a male smoker's disease. And therefore we have to think outside the box in terms of how we're going to address that unmet need to capture that, that neglected population of the high-risk non-smoker and never smoker, the majority of whom are women. Next, please. The final trial data to share with you before we move into the bit about AI is researchers in Taiwan tried to address this question. This is the TALENT study, perhaps quite pertinent, although it's a more homogeneous population, more pertinent than the Western data I shared earlier. And this trial looked at screening for lung cancer in non-smokers or never smokers. And you can see they looked at certain risk factors, including a family history, secondhand smoke or tobacco exposure, cooking index, cooking without a ventilation, and so forth. Because there's various theories as to why non-smokers get lung cancer. And what emerged as statistically significant was a family history. The more first-degree relatives one had, and particularly if it was a sibling, a brother or sister, it increased the risk of around 1.7 to twice as likely to develop lung cancer. So it appears, limited data, but one major trial, that family history, a significant family history, is a significant risk factor for lung cancer in the non-smoker or never smoker. Next, please. So I think we all can agree screening achieves stage shift to stage migration in those who pick up more early stage disease, consequently can be treated more effectively, therefore more cost effective, cheaper to the patient, the caregiver, the family, the healthcare system, the society at large. And it translates into actual reduction in lung cancer specific mortality. Next, please. So the next part of this talk is, before we dive into how innovative AI can aid this process of screening for lung cancer, we need to be cognizant of what are the existing barriers to screening for cancer in general and lung cancer specifically. So what I've done here is I've highlighted, in my opinion, on the left in red, what are some of the barriers that potentially can be mitigated or surmounted using AI. And of course, as you can see in white are the human factors, that any of us or our family, if we are in this unfortunate situation, AI is not going to help with that. We need good old-fashioned human relations, empathy, good communication, awareness. So generally, we hoped post-COVID health literacy will be better, but it looks like the uptake is still pretty poor. So as healthcare professionals, as NGO society, as regulators, we have to push the needle and continue to raise awareness, okay, and communicate effectively to the wider public. And the same goes with patient anxiety, fear of a cancer diagnosis. These are real issues that AI is not going to help us with. But in terms, I would like to address a few of these. So in terms of a cost, a low-dose CT scan, which still remains a standard of care at the moment, in Klang Valley, in the private setting, anywhere from 400 to 800 ringgit for an LDCT. Contrast that with a simple chest X-ray, which is around 50 to 60 bucks. Okay, even if you add the AI technology, it's a few ringgit more. So potentially more savings. I'm not advocating that a chest X-ray or an AI-enabled chest X-ray replace the LDCT, but I'm suggesting it may be used to complement as a triage to funnel patients before they go on to the definitive gold standard LDCT. Accessibility, okay, uptake. Part of it is related to the factors on the right in white, but part of it may be cost and maybe availability of accessing the healthcare system. So if we look at this little figure here in the bottom right, look at the uptake for lung cancer screening in a first world nation like the United States. Uptake only around 10%. And that's because there's a lot of gaps in their healthcare to access such technology and scans. They also rather erroneously didn't involve their primary care. In the UK, the uptake in recent times better, partly because they have decided to frame the lung cancer screening as part of a broader lung health check, which perhaps is the way to go, a bit like the AI screening being done over this weekend. Maybe it is less daunting and less frightening for an individual. And they've also involved the GPs. In Estonia, you can see the uptake very high. They've been very proactive, calling up people in a certain age group to come for screening. Radiation is another issue which I'll address in the next slide. Of course, we've talked about false positive specificity, which feeds into patient anxiety. And then the concern about increased workload and capacity. Can the system cope if we start finding more disease? But what I'm going to tell you is that with the AI technology, we can actually streamline and triage and identify the high-risk individuals who should then go on to get the LDCT. Next, please. So in terms of looking at the radiation, and this is a question we commonly get asked by our patients in the clinic, the way we quantify the radiation dose is in terms of millisieverts. And you can see, just for context, the average background radiation in the US per year per person is around 3 to 5 millisieverts. Now, a low-dose CT, which is what is required for screening, as opposed to the conventional contrast CT, is only around 1.5 millisieverts. That's still about 15 times more than a chest X-ray. And you can see the contrasted CT, which we do for other reasons, is around 7 to 8 millisieverts. So you can see, if we deploy AI-enabled chest radiographs thoughtfully, appropriately, we can screen more people cheaply and reduce the radiation dose. And remember, screening is a process. It is rarely an isolated test. Patients will need follow-up surveillance scans over a period of time. Next, please. So at this point, I just want to share our experience. So the NGO that I lead, Lung Cancer Network Malaysia, we conducted a feasibility, a pilot study in collaboration with the Qualitas group of GP clinics, kindly supported by AstraZeneca Malaysia. And we ran this study in Klang Valley, urban setting, very small scale, from May 2021 till February 2023. As you can see, a lot of that was during the period of the various MCOs during the pandemic. So over 16,000 people were screened. Many of them are not patients in a primary care setting to go to the GP clinic. And our detection rate was about 2.35% for an IPN. An IPN being an indeterminate pulmonary nodule. In layman's terms, a lung nodule. As we all know, not all lung nodules go on to be lung cancer, but all lung cancers will manifest initially as a lung nodule. So the idea was, people went to their GP either because they had symptoms, could be chest-related symptoms or any symptoms, or they just went for a checkup. And the GP, as part of their assessment, history-taking evaluation, if he or she felt an X-ray was a relevant investigation, went on to do it. The X-ray was then done. It was uploaded to a cloud-based AI software, which I'm going to share with you shortly. It then generates a report within less than 2 minutes. And then the GP is empowered on the next course of action. If patients were smokers or high risk and had a normal X-ray, they were still counseled and offered low-dose CT screening based on the trial data. Obviously, if they had an abnormality, then it was the GP to decide on the next course of action. And for those who had a lung nodule, they were then referred on, or at least the idea was for them to be referred on to one of 3 centers for the LDCT and for a consultation with a lung specialist. Next, please. So I'll come back a little bit to that. So this is the software that we used, and I would like a disclaimer here. I have no vested interest in QAI. It's an Indian-based software. I believe at the present time it's now the most widely deployed AI software in the world for healthcare. And it's a cloud-based software. And basically it's called QAI. It can detect nodules, it can detect masses. It even has the potential to assign a malignancy score index, or to help stratify what looks like a malignant nodule. And what the primary care, outside a hospital setting, the value is, and it generates a very detailed report, commensurate with that of a trained thoracic radiologist within a matter of a couple of minutes. Next, please. So, in submitting their sort of software to get FDA approval, they had to provide a lot of evidence, as you can imagine. So we see enhanced diagnostic sensitivities. They looked at 300 random X-rays and CT scans, read by clinicians, radiologists, pulmonologists, ER physicians, who read it with and without the help of the AI software. And they were able to demonstrate that 40% less nodules were missed when the readers utilized the AI software to aid them. In other words, we are increasing, you can see the sensitivity has improved with and without the QAI, the software, from 72 to 83%. Importantly, without increasing the false positivity, without reducing the specificity. Next, please. In terms of the malignancy score, at the time we didn't have this. I'm told my time is up, so let me fly through this. No, just go back to that, sorry. So we look at certain criteria: the size of the nodule, whether the shape, whether it's spiculated, whether it's homogeneous, calcification, usually a sign of benignity. And then we can assign a score, and then perhaps we stratify and look at the high-risk nodules. Next, please. So how does it work? It can actually reduce the workload, complement the work of the radiologist, rather than compete with them. So, for example, you do the X-ray in a clinic, in a hospital, it gets uploaded to the AI software, a report is generated. If it's normal, the radiologist can just sign that off with minimal review. If it's abnormal, they review it, sign it off with the report. If a lung nodule is flagged up, and a high-risk lung nodule, then it can trigger proceeding to the LDCT and further investigation. Next, please. Again, the same software that we utilize, used in 7 trusts in the NHS in the UK, and it should improve turnaround time. The whole idea is to expedite the diagnosis and referral of suspected cases. They were able to reduce the time for reporting of the chest X-ray from 15 down to 5 days, and also for a follow-up investigative LDCT from 45 down to 7 days. Next, please. I think I've mentioned this before in terms of improved sensitivity, high negative predictive value. Next, please. So basically, it consistently outperforms the human radiologist. Again, with the flow, if we can just go back 1 minute, the only point to mention is this software is cloud-based, and whilst it circumvents problems about the software, or rather having capacity within your own system, it raises issues of confidentiality, data privacy, but they have the ability to de-identify the data, analyze it, and then send it back and re-identify. So it can be done in a completely anonymized manner. Conclusion from my own study, and I don't have time to go into the details, but this is the feedback from our colleagues in primary care, in general practice. They found it easy to use, they liked it because they got a high quality image, a detailed report. As I said earlier, it empowers the GP on the next course of action, whether it's to treat the patient, whether it's for a follow-up scan, whether it's referred to a specialist. So you're shortening the turnaround time, you're enhancing the diagnostic accuracy, so it's win-win. Next, please. So my penultimate slide, what are the lessons we learned from our own screening? Well, certainly there was still very, very poor uptake, perhaps partly because a lot of it was conducted during the COVID pandemic. And I think that we need to address in terms of greater awareness. Perhaps, the idea of telling anyone to go for screening for lung cancer, is a frightening prospect. And so maybe we need to be like the UK, learn from them, frame it as part of a broader lung health check. There was a very high attrition rate, meaning patients have a nodule flagged up, and then we told them to come on a different day to a different place for the LDCT, and they were lost to follow. And even data from the Netherlands shows 60% of people with a lung nodule and IPN are lost to follow. So I think we need to be looking towards a single-day service, a one-stop, so we capture more of these individuals. Not easy to achieve, but doable, having a dedicated, what I would call as an IPN clinic, and that's something we're working on. A navigator, we introduced a navigator, but this is towards the end of our study. Felicia was in it. And I think if we were to do it again, we would introduce a navigator much earlier on. Someone who can shepherd, navigate the patient through that journey, follow up on them. But again, we have to be careful about how we contact patients. Patients didn't pick up the phone call or the SMS. And I actually think if you make things free, it often gets wasted. That's human nature. So perhaps some element of co-payment so that there's they turn up for the scan. Next, please. Very briefly, impediments to AI, obviously attitude, not just patients, clinicians. Sometimes radiologists may have concerns whether this is going to be something that disrupts their workflow, but actually it's something that can enhance their work, complement their work, not compete. Image acquisition protocols have to be standardized, but any variations are not artifact, but due to biological. Technical integration, the AI software, a lot of it, the computational power can retard, slow the scanner performance, so you need to make sure you have sufficient, you upgrade your server, your system. Next, please. So I want to conclude by saying that the adoption of AI-enabled chest radiography, in my opinion, can widen the net to try, it's scalable. We can deploy this in primary care GP clinics. We can deploy this in Clinic Kesehatan up and down the country. We are not going to be constrained by needing a highly trained, experienced radiologist on site. And then those x-rays that are abnormal, that are equivocal, that are flagged up, need to be referred on to a center to be seen by a lung specialist, or if we have a pathway well established, go on to get the LDCT. And again, you can deploy this remotely. My last slide, I want to end, next please, a glimpse into the future. So this is my final slide. This is an illustration of the awesome potential and equally frightening potential of AI. So this was published in the Journal of Clinical Oncology last year. Researchers in MIT, they developed software. They named it Sybil very aptly because for those of you who know in ancient Greece, the female oracles who can prophesize the future, they were called Sibyls. And this is what this software does, okay? It's deep learning algorithms, AI software developed on 3D convolutional neural networks. And they use a training data set, 28,000 patients from the NLSD data from a hospital in Taiwan, the Chung Gong Memorial Hospital, as well as Massachusetts General Hospital. And from a single low-dose CT scan for screening, a single LDCT, a one-off, with no clinical information, with no demographic information, with no annotation from the radiologist for an area of interest, they were able to predict with a high level of accuracy at 1, 2, 3, up to 6 years, the likelihood of going on to develop a future lung cancer. Just to illustrate, figures A and B, that is, in the upper lobe of someone's lung. And the figure A, I can assure you as a thoracic surgeon, you wouldn't give it a second look. Figure B is the same patient 2 years later in the exact location. A lung cancer pops up, confirmed by biopsy and operated in America. Similarly, C and D belong to the same patient. You see a tiny nodule in figure C where the arrow is. That's a nodule in the lingular segment of the left upper lobe, just abutting the heart. 1 year later, you see a classic spiculated lesion. So, the potential is immense. It allows us to personalize surveillance interval scans. It will allow us to intervene earlier, but at the same time, you can see the problem with that. It's going to create a lot of anxiety, not just for the patients, but for us as clinicians. How do we manage the person where we don't see visible disease, but we know they're at high risk? How do we communicate that? So on that note, I think it's very important that we be very judicious in how we adopt innovative technology like AI and how we implement it. But it's no longer a question of why or when, it's a question of how. When I was driving over here, I heard on the radio, well actually it wasn't today, a couple of days ago on BFM, that by 2030, AI across all industries is going to add $15 trillion to the global economy. So that train has left the station. Thank you. And apologies for overrunning the time.